Well, ladies and gentlemen, I'd like to welcome David Chang and Gaurav Luthra also for this course. Now, the first thing which I thought I will now talk to you about is a problem which we do see, but somehow we have not bothered about. And that's what I thought I'll show you. The first clipping of mine coming in. One of the problems in life which we face is when we see a case like this. This is sommering rings. Now you can see these sommering rings. The question comes, how do you manage them? Now notice here, the patient came to me from Iraq. He had a rupture. He was referred to me basically for a glued IOL. But when I saw him, I noticed the eye is large. Things cannot come out. Oh. If I leave them behind, I will produce a tilt in the IOL. They can drop down and produce inflammation. So after vitrectomy, what I'm doing is I'm first of all doing the glued IOL. So you can see I've externalized the first haptic. Now you can see I'm going to do a handshake technique, passing the faucet from one hand to the other, going in from the other side, catching the tip of the haptic and externalizing it. Can we make the brightness of your monitor there slightly more? Now once you have done that, notice the problem which I'm facing now. The problem is the amount of haptic externalized is very less. So what I'm going to do is I'm making another opening anterior to that. Now I'm going to re-internalize this haptic. Go back in again with the handshake technique, catch the haptic, go again from the anterior sclerotomy, grab the haptic tip again and pull it out. So now you can see I have re-internalized and re-externalized my haptic, and now you see the amount of haptic externalized is much more. Now the disadvantage in this game is if you do this, you might damage the iris. I've done it on the other side, and if you notice there was no iris defect, but now notice I have an iris defect present. So anyway, what I'm going to do now is again re-internalize, re-externalize the haptic. Once I have got it, I now create the Gabor Chariot's pocket. Once I have got that, I will tuck the haptics in. As you can see, I'm doing it just now. Now remember, there's a posterior sclerotomy also, so I don't need to have that. I'm going to just suture it so that I will not have an hypotony post-operatively. Case not over, ladies and gentlemen. I still have to attack my sommering ring, and the bargain, what has happened is my pupil has come down. So what I'm going to do now is dilate the pupil. So I'm using iris hooks to dilate the pupil, and now look how easily the sommering ring comes anteriorly. Now at this stage, I will then do some vitrectomy, undilate the pupil back again. So you see now I'm going to undilate the pupil, means I'll remove the iris hooks back again. Now what have I done? I have done a glued IOL which is now going to work like a scaffold. Now I can go in with a phaco probe, and before you can say bingo, that sommering ring is gone. So you can see this is a glued IOL scaffold for sommering ring. Case not over, ladies and gentlemen. I still have to work on the iris we messed up with. So I'll use the Mechanel suture or any technique, but a great man, Mechanel, who started this from Minneapolis. I'm going to use that technique, suture it up, and thus close up that iris defect also. So once you have done that, now the case looks much better off. So now I'll just suture off that area, apply some air inside now. So I'm going to do some stromal hydration, apply air, seal the whole thing with glue. Why do I apply air? Because I don't want any hypotony. Now the question comes, how did this patient behave? Because in the end, that's the bottom line which we have to ask ourselves. So let's see how this patient behaved. And you can see here I'm applying the glue. This is the same patient post-op day 4. You can see how the patient has improved to 20/30, and 1 week post-op he improved to 20/20. Some other cases you can see of post-operative of sommering rings pre and post, all managed with this technique of the glued IOL scaffold. Saying that, ladies and gentlemen, the next thing which I thought I will show you is a patient who came to me with an injury. Those in the back, please come in the front. There are rows in the front which are empty, and then more people can enter because I can see there's a backlog there. Audiovisual, if you can help me by just making that brightness of your LCD monitor. No, make it brighter.
I said buy a new computer. Buy a new computer.
Buy a new computer. So now you see this patient here. The patient had a history of a trauma. Now I've sutured up the clear corneal wound. Now you see the next step here is I'm going to go in for my phacoemulsification. Obviously rhexis is going to be difficult. So I'm going to do my rhexis, complete it as much as I can. But I know something has gone through and through. So obviously there is going to be trouble. So I'm going to do my hydrodissection. Once I have done my hydrodissection, you will see the cataract coming off. Obviously it's a young patient, so the soft cataract is there. I go ahead, try to remove my phaco as much as I can.
Can you off these lights, please? Off this light.
And you will see now, once I have done that, you'll see my next step is, gradually I remove that cortex, but to my dismay, you will notice there is obviously a posterior capsule defect. Now when the posterior capsule defect is there, what do we see there basically is vitreous coming out, as you can see there. But look at that shine. There is something moving there, and that is the intraocular foreign body which just went through and through. So what I'm going to do now is, I'm worried about that intraocular foreign body which is lying right now in the anterior vitreous. The vitreous is there, so I have to do some vitrectomy obviously. But my next step is I don't want that intraocular foreign body going down unnecessarily. So the question is whether I can catch it before it goes down. So I've caught it there with one hand. Now at this stage I am not pulling it out. I'm going to do at this stage a vitrectomy, clear up this whole area there, and you can see I'm doing that with a vitrectomy. At the same time I'm infusing fluid inside. The foreign body will not go anywhere because I've got it held with the forceps. Now once I have got the foreign body inside there, I want to remove it. Now I cannot remove it with my left hand, as you can see, because the long axis is not matching it. So what I'm going to do is I'm going to go all around the foreign body, and you can see I'm doing a vitrectomy, clearing it all up so that I don't have any traction. Once I do that, I've used an intraocular magnet, and you can see this, an intraocular magnet there. I'm catching that, and once I see the intraocular magnet holding it, again I'm not pulling it out, I'm doing a vitrectomy around it, and you can see the intraocular magnet pulling it, and the whole intraocular foreign body has come out. If I did not have an intraocular foreign body which was magnetic, I'd have removed it with a forceps, but I've done a handshake technique. Once you can see the foreign body out, now my question comes, do I have enough sulcus support or not? So if I have enough sulcus support, I will put the lens into the sulcus, any 3-piece IOL. If I did not have it, I'd have gone for a glued IOL. Now I'm just showing you here the intraocular magnet, and you can see how it catches on quite well. Now you can see the next step is I'm assessing my rhexis margin, etc. Once I have done that, I know I might as well do a proper vitrectomy. So I've got my trocar cannula fixed. I'm going ahead, completing my vitrectomy. Once the vitrectomy has been completed, then the next step is for me to go ahead and implant the intraocular lens. Implanting an IOL in a sulcus in a PCR sometimes is tough. A simple trick which I can tell all of you is use iris hooks at this stage if you want. I'm not using it in this clipping, but you can use that. Assess exactly how much of rhexis margin you have. But in this case I've been able to do it comfortably, quite easily, and finishing it off. So now you can see this is how the case looks when it's completed now. Now let's see how the case looks at the end, because as I always believe, the end point is always how a patient looks at the end of surgery. So we'll just see that just now in a second and assess how this patient is. You can see how this patient is looking post-op day 1. The patient's vision has improved to 20/30 already, and subsequently came up to 20/20 vision. Now one more thing which I wanted to show you people here is another patient who had, now this particular patient had a scarring also, and I thought I should show you this clipping. Those in the back, Please come in the front and sit down here, because we will have others also speaking, and you will be more comfortable here and more people will be able to enter the hall. Now let's look at this last thing which I wanted to show you here. And I think we are very grateful to have Dr. Kalevar here in the hall sitting here with us. Now this was a 9-month-old donor eye. Now what I'm doing here is I'm taking a 30 gauge needle, I'm entering into that cornea, and you can see I'm creating a type 1 big bubble. Now when you create this type 1 big bubble, basically what you're doing here is you're separating the endothelium, desmase, and the predesmase, which is the Duas layer on one side and the stroma on the other. Remember, this bubble does not go to the periphery. If it went to the periphery, the bubble is between the predesmase and the desmase. Once you have got that, I'm going to go inside, inject some trypan blue, and now you can see here a full scarring present in this patient. Now the patient has a subluxated intraocular lens also at the same time. Now I've taken off the epithelium, and after taking off the epithelium, I still notice huge amount of scarring present. So I'm making my two scleral flaps 180 degrees apart. Once the flaps are there, I know obviously this patient will go in for a glued IOL. So once I've made my two flaps, the next step for me is to obviously go in for infusion in the eye. So what I'm going to do now here is I'm going to have fluid in the eye. Now I will have to explant this IOL. By and large, I might refix the same IOL, but I think this IOL is deformed. And when an IOL is deformed, it's better to pull it out. So what I'm going to do now is fix my trocar cannula inside. Once my trocar cannula is inside that eye, the next step for me is to go ahead, do some vitrectomy and explant that IOL. Now the media is absolutely hazy. I am not able to see well because of the corneal scarring present and the distortions present. But remember, one advantage in the glued IOL is, even if the media is so bad as what you're seeing right now, one can still do a glued IOL. Just imagine the scarring is there, and imagine if you're operating, it's still tough, but we can do it. Once you have done that, you will notice I made my tucks there, and the haptics both are tucked. Now, once my both haptics are tucked, remember one problem. When I put in my air for my graft will detach because the air will go behind. So I'm doing a pupilloplasty to make that small. The glued IOL then works like a trampoline and becomes one conglomerate area there which pushes the air up. Now I go in, take off the endothelium out. Once my endothelium is out, I take my PDEC graft, which I've kept in MK medium. Simple trick is load it onto a simple MIL injector of yours. I got this trick from Francis Price, and once this is a simple IOL injector, you don't need any fancy instruments when you're doing this PDEC. I then take this inside and I'm injecting it inside just like you will do a normal IOL injection. Now remember, question comes, how do I know which side is right? Simple is, off the microscope light, use your endoilluminator. This is the endoilluminator assisted PDEC, and check the graft position, which side it is curved. And you see there now, I'm now unrolling the graft, fixing it back. Once my graft is fixed, I then seal everything with glue and then close up the case. Now the question comes, how did this patient behave? So that's the same patient, post-op day 1, you can see pre-op, post-op, and you can see the anterior segment OCT below. Now the question comes again, with time, do these patients improve more and more? And you can see here, post-op day 4, you'll notice the epithelium growing better. But watch, 1 month post-op, look at that scarring which was there, is all gone. That's 45 days post-op. That's the anterior segment OCT done at that time when we did it at 45 days post-op. But most important for this patient is, when you will compare the pseudophakic case pre-operatively, how bad it was, this is without the epithelium. And now when you see the same patient 45 days post-op, you will get a comparative defect. This is the same patient 3 months post-op, and the final picture which you see here is pre-op, 3 months post-op, and you can see the massive difference, and that's the final picture 6 months post-op. Saying that, ladies and gentlemen, I'd like to thank you all for having me in this lecture here, and ask Dr. Atya to come and speak to us on her nightmare situations.